This is actually a page stripped out of Frederick Banting's notebook, the night where he decided that he could figure out how to extract insulin from a dog. And ever since then, for the next 40 or 50 years after this, 1920, diabetes was thought about as a pretty simple disease, right? You lacked insulin, you gave back insulin, and then everything was fine. However, that's not how things panned out. And in particular, how do I move this forward? Right. We come down to 1949 when Sir Harold Hemsworth had come up with this test that he called the glucose insulin test. And essentially what this was a simple test that could figure out whether you lacked insulin or whether you were insensitive to insulin. And he discovered that if he did this test on lots of people, there were actually two kinds of patients with diabetes. There were those that were very insulin sensitive, which we would now call type 1 diabetes, young, thin. He describes them very well, very prone to develop ketoacidosis. And there was another type which looked like they were insensitive to insulin, and they didn't develop ketoacidosis, and they had all of the features we now call, having the metabolic syndrome, obese and having a high cardiovascular risk and so forth. So it's a very prescient paper, a long time back in 49. The problem with it, though, is that ever since, we've been stuck with this very archaic classification of diabetes as type 1 and type 2. Which all of us recognize, and endocrinologists in particular, that this is absolutely inadequate, and yet we stick with it. We take a very, very complicated illness and divide it into two kinds, even though it's incredibly heterogeneous. It's as if, you were to go to an oncologist and the diagnosis is, well, I think you have type 1 or type 2 cancer, and I'll give you this, and they'll say it doesn't work, we'll give you something else. So that's kind of the state of the art in terms of thinking about the complexity of diabetes. Now, the trouble with this also is it's very hard to define. If I were to take a room full of endocrinologists and ask them, can you give me a clear, pithy definition of type 1 and type 2? They wouldn't be able to do it. They'd kind of spend 5 minutes saying it could be this, it could be that. And generally, if the patient in front of you is early onset, young, is lean, has these antibodies, these islet antibodies, doesn't have a family history, gets ketoacidosis, and has certain HLA associations, you say, well, I think you have type 1 diabetes. On the other hand, if the patient in front of you has late onset, is overweight, does not have the antibodies, has a strong family history, does not need insulin, does not get DKA, et cetera, you say, well, you probably have something called type 2 diabetes. The problem, though, is that everyone here who does primary care, internal medicine, endocrinology realizes that people not almost always, but often do not fit neatly into these boxes. And over time, the American Diabetes Association has said, well, there are a few other kinds of diabetes, and they define these, right? So diabetes with exocrine pancreatic disease, genetic syndromes, neonatal diabetes, getting diabetes with other endocrine disorders like acromegaly or Cushing's. And there's also something called monogenic diabetes, which is considered rare and is the disease because of a single defect in a single gene. Now, this is better than pushing everyone into a type 1 or a type 2 box, but it's still extremely inadequate. One of the reasons it's inadequate is because if you notice, none of these categories have an etiological basis. They're very descriptive, right? And if you ever want to get to the stage of something like precision medicine, you really want to describe endotypes. Endotypes meaning not only a phenotype, but something in there which gives you a cause or a mechanism, something where you can use targeted treatment. And with the possible exception of monogenic diabetes, none of these fits that requirement. So how do you think about the disease? Well, one way to think about the complexity of diabetes is that there is a type 1 and a type 2, but they tend to overlap. And many people kind of fall in the middle. And this is true. In fact, this does happen. And we've are well sort of familiar with something called latent autoimmune diabetes of adults, which in fact is a perfect overlap syndrome. The people who are labeled with LADA tend to be adult in onset. They don't need insulin when they start off, so they look like type 2 diabetic patients, but they have the type 1 antibodies, and they generally tend to be somewhat leaner, and over time, they lapse into insulin requirement much faster than most other people with type 2 diabetes, right? So this kind of, seems to be a way to understand it. Now, in most cohorts of type 2 diabetic patients, LADA is something like 6%, up to maybe about 10 or 11% if you do the careful studies, right? And I'll point out that maybe that is not enough in just a second. What you're really saying is that the autoimmune basis of type 1 diabetes can bleed into type 2 diabetes. And the question is it a different disease? Now, recognizing the heterogeneity of type 2 diabetes, the fact that people behave very differently, a wonderful group in Scandinavia, in Sweden, have taken this large longitudinal cohort and done cluster analysis, basically machine learning kinds of approaches, using a lot of well-documented but pretty simple clinical parameters, right? So things simply like age and BMI and your A1C, a measure of an antibody, which is the GAD antibody, a simple measure of insulin resistance and a simple measure of insulin secretion. They've taken these things together and done AI kinds of work and come up with these 4 or 5 different subcategories of type 2 diabetes, right? So they've taken what we currently know, which is mostly type 2 with a little bit of LADA, and using this mechanism, they've come up with 4 different types of type 2 diabetes and this one overlapping thing. Now, what do all these things mean, and is it helpful in practice? Well, it's turning out that even though this is quite recent, it really might help you understand your patients better. So SAID, which is severe autoimmune diabetes, but in a type 2 patient, is essentially LADA, what we were talking about. But there's also SID, which is severe insulin deficient diabetes without the antibodies, and SIRD, which is severe insulin resistant diabetes, and so forth. So they are phenotypically different, and you can actually make this diagnosis in the clinic. But is it useful? Well, it turns out the reason this is useful is because it actually predicts behavior, and it might be able to help us with treatment. So I'll just give you a couple of examples. SIDD, which is the severe insulin deficient diabetes, people who look like type 1, but they're late onset and they don't have the antibodies, do particularly badly in terms of retinopathy and neuropathy. You can't see the colors very well, but basically the top lines over here are the SID patients compared to other type 2 patients, right? So if you were able to categorize people in this fashion, you would be much more careful and watching out for things like retinal screening and neuropathy. On the other hand, if you categorize a patient as having SIRD, which is the severe insulin resistant diabetes, notice that these 2 groups are the ones that have the really terrible manifestations of metabolic syndrome. They're the ones with the earliest onset of chronic kidney disease, as well as a much higher rate of heart failure. Right? So these are fairly simple clinical tools, and whether they apply to non-Scandinavian populations is being worked out. But it's a fairly, I think, useful way to start teasing out the heterogeneity of type 2 diabetes and being able to understand better. Now, it will be really helpful if you can figure out if there are specific treatments that work better in these groups, and those studies are ongoing. However, I think it's even more complex than that, right? So let's go back to this overlap. Remember that this overlap, or LADA, is you're defining a group of type 2 patients based on type 1 antibodies, which is, very sort of elementary, because autoimmunity is much more than a few antibodies in a given disease. What if there were other antibodies that still could define autoimmunity in type 2 diabetes, or in fact, the whole cellular aspect, right? So antibodies only give you the humoral aspect of autoimmunity. What about cellular autoimmunity? Well, to cut a long story short, our group with some others took a very wonderful long-term trial in diabetes, recently published, called the GRADE study, which in itself has some wonderful, I think, guidelines as to how to go about stepwise treatment of type 2 diabetes. But we took advantage of these patients because they were very well characterized as having type 2, not type 1, and took a subset of them and really tried every kind of immunological test to figure out if they have some kind of islet autoimmunity. So we measured not only the antibodies, but also looked at cellular autoimmunity. It's an interesting test. And the bottom line was, it turned out that 41% of these patients defined as having type 2 actually had T-cell mediated autoimmunity directed against the islets. Another 13% had the humoral autoimmunity. In other words, they had the antibodies. They were the LADA patients. And again, interestingly, there was not much overlap between the T-cell kind of autoimmunity and the humoral kind. So really suggesting that there may be 2 different kinds of islet autoimmunity, even in patients who look like classic type 2 diabetic patients. And the most important thing is that those guys that had the T-cell autoimmunity had decreased insulin secretory capacity, they had decreased beta cell function, and they had higher glycemic levels. Now, this is the baseline study. We're now doing the longitudinal studies to see if being T positive also means you have a different natural history. The studies are ongoing, but just want to point out that there is this overlap is more than just a few people carrying antibodies. It really may be much more complex, and there may be this whole other aspect of autoimmune destruction of the beta cells, which is essentially what leads to the worsening of diabetes and the worsening of metabolic control. So this kind of thing and a whole lot of other studies have led us to believe that we really should not box people into two kinds of diabetes. And there's really a spectrum, right? So even though there are such people as typical type 2 and certainly typical type 1, there's a range in between. And in clinical practice, you're given 20 minutes to get your RVUs and get through a patient, you see a new patient, your first instinct is to take anyone that looks sort of greenish and put them into a type 2 box, anyone who looks kind of bluish, call them type 1, and then go on with your life, right? And you often find that there are people in this spectrum who are not exactly responding to what you're saying, they're behaving differently. So if you have the time to sit back and think about this as a spectrum, you can actually visibly see people with different phenotypes. And this is what, a number of people, including ourselves, have done. And I've listed here a number of these syndromes that are clearly atypical, but you can actually observe clinically, right? So right in the middle between type 1 and type 2 is LADA, as we described. But on either side of it are these things called KPD, which stands for Ketosis-Prone Diabetes. We'll describe that in a little bit, and certain kinds of monogenic diabetes. But there's a lot of spaces in between, and I think it behooves us to figure out what's in those spaces. What are the other forms of diabetes? Are there 100 different ways of getting to the common endpoint of hyperglycemia, which is how we define diabetes, right? Just as there are hundreds of different ways to achieve mitotic dysregulation to end up with a final common pathway of cancer of some kind. So how do we figure out the complexity of diabetes? By looking at or looking for atypical diabetes. Now, there's a pretty sort of long and distinguished history of people already, describing forms of atypical diabetes, right? There's the monogenic kind, of which one section is called MODY, which is maturity onset diabetes of youth, which is monogenic disease. There are syndromic kinds of diabetes, something called Wolfram syndrome. There's a whole range of diabetes that's caused by primary mitochondrial defects. And we never look for them, but it's really worthwhile. If you have a patient in front of you, relatively early onset, and they also have some deafness, or they have an early cardiomyopathy or some kind of muscle disease, or a family history of deafness, you should get mitochondrial genome sequencing. They might well have mitochondrial disease. What we detect right now is just the tip of the iceberg. There's ketosis-prone diabetes that I'm going to talk about. There's lipodystrophic forms of diabetes. Kids are getting type 2 diabetes, as you know. And the most interesting among them, I shouldn't say interesting, but the most, I think, intriguing in terms of the new form of diabetes are the ones that are pre-pubertal. Because very often in kids, type 2 diabetes is blamed on the puberty hormones. But what if a child gets it before, which is about 8 or 10% of kids now being diagnosed as type 2? So what is the reason for their diabetes, right? And so on and so forth. And lack of response to drugs is a very good way to figure out if someone is unusual. Right? Everyone loves the GLP-1 agonists now. They make you lose weight like crazy. They sort of almost cure hyperglycemia. But there's a core of people who never respond to it. Are they telling you something about the fact that the incretin pathway is not working? Right? So there's a lot of different ways of looking at it, and I'll show you a couple of ways in which it's proved to be very productive in medical practice. One is the discovery of MODY syndromes, right? It's been done painstakingly by a lot of excellent investigators, and the list of single gene defects leading primarily to beta cell dysfunction, leading primarily to insulin secretory defects, are called the MODYs. I've listed 14. There's more of them as we speak. Interestingly, most of them are actually mutations in genes that encode transcription factors for beta cell development. So the whole idea of how you develop this incredibly complex islet is tied into why you might later in life, develop hyperglycemia. And it turns out that although there's really lots and lots of different MODY syndromes, the top 4, MODY 1, 2, 3, and 5, account for about 80 or 90% of most MODYs. And even though in many populations it's thought to be like 1% of diabetic patients, it's mostly because we don't look for it. And now there's a much more algorithmic way, evidence-based way to decide who to do the genetic testing for. One way is to use this thing called the MODY prediction calculator, which you can find on the website. There are some other algorithms you can develop as well. But the point is that in general, implementation science has found that if you take something like 20,000 diabetic patients in your health system, something like 2,000 of them might meet the criteria for genetic screening for MODY. And if you actually screen all of them with a MODY panel, something like 15 to 20% of them end up having a MODY, which actually ends up with a change in management. Because if you diagnose MODY 1, you can take them off insulin. Most of them are misdiagnosed as type 1 and give them a low dose of sulfonylurea, and they do even better than with insulin. Same thing with HNF1 alpha or MODY 3. If you diagnose MODY 2, which is a glucokinase mutation, you can stop all treatment. It's almost like, an irrelevant kind of hyperglycemia with no real chronic effects. So this, it really changes management, and I think it's looking for them and using this kind of evidence-based screening that can make a difference. Now, I want to spend some time talking about things, kind of an approach that our group has taken to flesh out another whole category of atypical diabetes, because I know that you see this in practice, and it'll be great if you could characterize these patients and find out more about what makes them happen. And these are patients who present with diabetic ketoacidosis, which was thought until about 15 years ago to be exclusively the domain of patients with type 1 diabetes, but they don't have the features of classic type 1 diabetes, right? So the question is, why do they develop ketoacidosis? What is unusual about the way their islets function? And this started off as a series of sort of scattered case reports during the 80s and early 90s. And, sometime in the 90s, we decided to take it pretty seriously and did essentially a longitudinal study in a registry, which continues till today, where everybody who comes into our county hospital with DKA is not given a name. We don't call them type 1 or type 2 or anything else, but we collect all of their data. And in particular, we found that measuring the islet antibodies, as well as measuring the amount of reserve they have for insulin secretion using something called the C-peptide measurement, in addition to a lot of other things, and following them prospectively might give us a clue as to what are the syndromes here and how do they behave. And in particular, we were intrigued by the fact that a good chunk of these folks in an inner city, multi-ethnic US urban hospital coming in with DKA, a significant chunk of these folks came in with florid DKA, but would come off insulin within 2 or 3 months and do fantastically for 3 or 4 years, right? In other words, with good A1Cs and not requiring insulin. And we were all taught to never take somebody who's ever had DKA off insulin. So what's going on with these guys? Anyway, to cut a very long story short, analysis of prospectively followed folks ended up with giving us a classification based on multivariate analysis that showed that 2 factors, whether or not they had the antibodies and whether or not they had some degree of beta cell function remaining right after the DKA, could actually categorize people very well. So you get this 2 by 2 factorial, and you can be A plus or minus, and you can be B plus or minus, and you get these 4 categories. Now, if patients are A minus and B plus, which is this quadrant, they're well known, right? Those are the patients with autoimmune type 1 diabetes. They have the antibodies, they don't have the beta cell function. But those guys comprise only 20% of people who walk into US emergency rooms with DKA, right? In this day and age. So what about the other 80%? Well, it turns out that 10% also look autoimmune in the sense that they have the antibodies, but they're much older. They look like type 2 diabetic patients. And amazingly, despite having DKA and despite having the antibodies, they come off insulin for long periods of time. So it turns out they actually have a different kind of autoimmunity, much more slow, different epitopes to their antibodies, different HLA markers, and also certain protective alleles. So it's a whole different kind of autoimmunity, kind of like that T cell variant that we talked about. There's about 20% that look just like your typical type 1 diabetic patient, except they lack the antibodies. And these guys have a very genetic flavor. About a quarter of them, as I'll show you, actually end up having a new monogenic kind of beta cell dysfunction. So they're prone to DKA despite not having the autoimmune destruction. And 50% are the most mysterious because they look exactly like type 2 diabetic patients. In our ethnic population, they're predominantly Hispanic or African-American or Asian. They're overweight. They come in at the age of 45 or 50, and they come in with florid DKA, often without any precipitating factor. So, and, it used to be thought originally that this was primarily, a condition that affected African-Americans or people from West Africa. That is not the case. It turns out those original reports was really a bias of ascertainment. If you look, you'll find these patients all over the world and in almost every ethnic group that I've seen reported. So what does it all mean? We want to get back to endotypes. If there are different syndromes, what do they tell us about different mechanisms of causing diabetes? Well, as I mentioned, this group at the bottom, over here is your classic type 1 diabetic. The group on top has a slower autoimmune kind of diabetes. The guys down here are enriched. They're not all, but they're enriched in beta cell defects, usually often genetic. And then there's this mysterious group over here, which are getting better and better characterized. So these guys, after they recover from the DKA, have well-preserved beta cell function. They can discontinue insulin, and they do pretty well. And although all of these studies were done in adults, we're now finding that we're getting the same thing in children. So children with type 2 diabetes can often also present with DKA. And our colleagues at Texas Children's Hospital with a very large cohort have found that if you take these type 2 diabetic kids with DKA, some 45% of them actually meet the criteria for what in adults we're calling A-, B+ KPD. So even in kids, I think we're going to start to dissect out additional forms or endotypes of diabetes. This is just to show you that there is also a kind of complex genetic basis to these differences. This is called the type 1 genetic risk score. I'm very hopeful that in the near future, 5 or 6 years, this will actually come into clinical practice. So, you can lack the antibodies, but you may still have a genetic predilection for autoimmune destruction or not. How do you tell that? It's not easy. One way is to take the 30 or 40 genes linked to type 1 diabetes, screen them all together, come up with a score. If you have a high score, you're more likely to have a type 1-ish syndrome with beta cell destruction. If you have a low score, you're not. And you can see basically just a couple of things. The A+, B- group has a high type 1 genetic risk score. The A-, B+ group has a very low one, not different from a control population, right? So again, this is not yet prime for clinical practice, but again, starts to tell us that there is not only a phenotypic difference between these syndromes, but also a genotypic difference between these syndromes. So that's the background. So let me walk you through some patients to see what they might look like. So here's a 44-year-old Hispanic man who comes in with DKA. It's a new onset of diabetes. He has a strong family history. He is very overweight and obese. He has evidence for insulin resistance. He gets the standard treatment for DKA, recovers uneventfully, and goes home. So what kind of diabetes does he have, right? You would say, well, sounds like new onset type 1 diabetes. So let's get some more information. And it turns out he doesn't have the antibodies. So it doesn't look like type 1 diabetes from that standpoint. And he has very substantial amounts of C-peptide. These numbers may not mean much to you, but actually numbers like 3.6 and a stimulated level of 6.6 mean very robust beta cell function. So there's plenty of insulin. Why did he develop DKA? And not only that, he comes off insulin, he's just on metformin, and we followed him for 4 years with great A1C levels and no recurrence yet. So why did this happen? So our diagnosis right now is this category of KPD that we call A-, antibody negative, beta cell plus, A-, B+. And we've followed several hundreds of these patients, and all of you see these patients in your ER, I'm convinced of that. And the thing about this is that if you follow these people for long enough, they kind of break down into two groups. So you're always kind of splitting these guys into other groups. So the top graph shows you a measure of beta cell function, and the lower one shows you the A1C. So all of these people got better beta cell function after the DKA. After a couple of years, half of them relapsed back to poor beta cell function, and half of them actually maintained it. And the A1C is the inverse. The guys that lost beta cell function, their A1C creeps up, and the guys who preserve it, their A1C stays down. So why are they behaving differently? It turns out amazingly that with a multivariate analysis, that the biggest difference between these two groups is whether or not that initial DKA had a provoking factor, right? So I have no idea exactly why that should be the case, but it's a very good clinical marker. So taking a history in these patients, was there something, was there a car accident? Was there an MI? Were you on steroids? Was there a psychological breakdown, right? If that is what sort of accompanied your DKA, you kind of fall into the provoked group. If there was nothing you can hang your hat on, it's an unprovoked group. And why do you care? Because they are very different syndromes. The unprovoked group is male predominant. It doesn't seem to have any of the markers of autoimmunity, including that T cell test. What they do have, interestingly, are defects in protein metabolism, right? I'll give you a little bit of a flavor for that. On the other hand, the guys who are provoked, they tend to sort of have this kind of occult autoimmunity, the kinds that we don't measure. They don't have the antibodies, they're A-, but they have this T cell reactivity in many patients. There are probably other reasons as well. So the really kind of novel group out here is the unprovoked A-, B+. Again, as I said, commonly seen in our urban ERs. And if you follow them, the question is, what is the defect in protein metabolism, which is unusual. With used to thinking of diabetes as a defect of carbohydrates or fats, not necessarily primarily of proteins. So this is just to give you kind of a summary of a lot of studies trying to understand why this happens in these patients. And I know it's complicated. All I want you to see is that a combination of static measurements using metabolomics and kinetic measurements using isotopes allowed us to sort of map out the places in the metabolism of these two amino acids, happens to be leucine and isoleucine and valine, the branch chain, just to sort of answer the question, why are these folks prone to ketoacidosis? But one scheme is that they excessively break down leucine from their muscle. Leucine is one of the rare ketogenic amino acids, so they produce a lot more of that when they're fasting. There is a branch point in the catabolism of leucine which actually arrests the TCA cycle exactly at the point of alpha ketoglutarate. So everything beyond that slows down. So the combination of producing more ketones when they're fasting and not being able to oxidize them allows you to have generally more beta-hydroxybutyrate. And these patients, even when they're really stable, are about 2 or 3 times higher levels of beta-hydroxybutyrate than equally obese non-diabetic folks. So the hypothesis is that they're always somewhat ketotic. And if something else happens, they might get kicked into ketoacidosis, right? Well, what is it that might do that? Well, it turns out that another subset of these folks, same phenotype, also have a defect in arginine metabolism. So why is that important? It might be important because arginine is a very important secretagogue of insulin, right? It's not quite as good as glucose, but it's pretty darn good. And you might need it at a time when your beta cells are struggling. They might need that extra kick. And this basically shows you that using isotopic methods, that the availability of arginine to be able to stimulate the beta cell when you're hyperglycemic, so these folks are studied when they're euglycemic and also when they're hyperglycemic, there's a great drop in the reserve of arginine in beta cells in these patients when they're hyperglycemic. So that's true. If you give them back arginine, are they able to secrete better? So early days yet, but some of our early studies are quite intriguing. This shows you what happens to insulin response to glucose when you're euglycemic or when you're hyperglycemic, studying the control patients in squares and the KPD patients in triangles. You can see the controls make a lot of insulin when they're euglycemic, and they make even more insulin when they're hyperglycemic. And the patients, like diabetic patients, have very poor insulin secretion. This is in response to glucose. However, if you give them arginine instead of glucose, their response almost completely becomes equivalent to that of the controls. So it really suggests that, sort of a timely delivery of arginine might actually keep these people out of DKA. Now, that's a big proposition. Proving that is difficult. There's some clinical trials ongoing. But the main point out here is that there are different pathways that seem to be affected in the way in which people develop even something as unequivocal as ketoacidosis amongst a range of patients with diabetes. Now, I mentioned before that sort of Scandinavian group had used cluster analysis and AI methods to try to tease out different forms of diabetes. They did that with sort of categorized type 2 patients. We've applied the same kind of methods to patients already known to be atypical, right? So if you take different populations of patients, sort of tease out those that are typical type 1 or type 2, take everyone else in the middle, and do these cluster analyses, you end up with this fascinating result that there are different subgroups of atypical diabetes in different populations. Here's a population in Cameron County, which is the southernmost county in the United States, right down on the Mexican border, 95% Hispanic. And one wouldn't think they have atypical diabetes. One would think they pretty much all have typical type 2 diabetes. And yet within that group, there are 4 clusters at least, which comprises about 12% of that diabetic population who have unusual forms of diabetes, right? And the question is, what is the reason? You apply the same algorithm, it's a software program called Discover Atypical Diabetes, and you apply it to a children's hospital. Again, you find that amongst kids called type 1 diabetes, there's at least 2 different forms, right? So the whole idea is that there is, we can use the data we have, we can use other methods to figure out these atypical forms of diabetes, which brings me to a wonderful study we have ongoing called RADIANT. RADIANT stands for the Rare and Atypical Diabetes Network. And I'd like you all to know about this and go on the website because all of you can participate in RADIANT. If you have a patient who looks unusual or even doesn't seem to fit type 1 or type 2, please give RADIANT a call. You can enroll the patient. I'll show you what is done to figure out what kind of diabetes that person has. And if your patient actually makes it into the study, you can be a full-fledged RADIANT co-investigator. You can follow your patient, you can be part of the workup, and you can be part of the publication that comes out of that workup of that patient. So RADIANT is run out of 2 centers. One is at our home at Baylor College of Medicine, the other one's at the University of Chicago. And collectively, we have a total of 15 different centers and core labs and so on and so forth. And the basic idea is to take people who look like they're not typical and figure out how many kinds of diabetes they have and what are the causes. So patients who enter RADIANT go through the following stages. They first apply online. There's a little algorithm that filters these patients. Then everybody else gets adjudicated by a committee to see if they're sort of atypical enough. If they are, they come into the study. They get whole genome sequencing. They then visit one of the sites that I mentioned. They have a very detailed exam. They get a number of other biochemical measurements. They have RNA sequencing done on their leukocytes, metabolomics on their plasma, and we store their leukocytes also for future work using stem cells, pluripotent stem cells. All that data then comes down to a discovery team, which is about 20 people. Half of them are geneticists, half of them are metabolic experts, to see what this person has, right? One case at a time. And then depending on what is found, we develop these sort of special interest groups that do a deep dive into a particular patient or a family or a cluster of patients. What we've generally found so far, after about 150 people have come through the process, over 1,500 have applied and come through, but into the pipe through the end of the pipeline, is that in about 10% of cases, there's something really exciting. There is a gene variant which seems highly likely to fit the phenotype. In 90% of cases, you don't get such a strong hit. What you get, though, are tighter phenotypic clusters. And in these special interest groups study them, as I mentioned, if your patient makes it through, you could be part of that special interest group. So here are some examples of what we call individual special interest groups. This is where you get that single variant that appears to be really striking. This is a partial list. The others fit into these things called phenotypic special interest groups, which again are kind of the grouping we did with ketosis-prone diabetes. Is like clinically, how do they behave differently? What more can we find out about them using AI methods? And I'll give you a few examples of where this discovery has led, just 2 examples. The top 2, a patient with a SMAD5 variant and a patient with a PDX1 variant, very quickly, just to give you an idea of how the discovery happens. And it's really interesting. So this patient was a 51-year-old white woman who had early onset of polycystic ovary syndrome, right? She had that, through her teenage years. And she married early and she wanted to have children and was infertile for 8 years, tried all kinds of things. Amazingly, when someone put her on metformin, she almost immediately conceived. And she has attributed all of her conceptions to metformin and she stays on that. During one of her pregnancies, she developed gestational diabetes as well. And subsequently, although she's quite lean and does all the right things and exercises, she continues to have diabetes. And she doesn't have the antibodies and she has robust C-peptide. So very unusual. The family history is interesting because the mother has a similar history. She has 2 daughters, one of whom has very severe PCOS, but doesn't yet have diabetes. And the other one has neither PCOS nor diabetes. And it turns out that in this case, as a result of the genome sequencing, the clue that came up is that she essentially has a heterozygous missense variant in this gene called SMAD5. And prediction algorithms suggest that this actually may be causing her disease. It also tracks in a Mendelian fashion. So here is the proband, the patient, and this is the variant, the C to T change in the nucleotide. The mother, as I said, has the same phenotype, but unfortunately refused to get genetic testing. But for the two daughters, the one that has the same phenotype has the same variant. The daughter who doesn't, who appears to be healthy, does not have that variant. So it seems to track with a trait. And the reason this is interesting is because this particular variant in SMAD5 subserves the intracellular signaling for a very important complex in granulosa cells. And this is through the hormone anti-Müllerian hormone. So anti-Müllerian hormone would engage this receptor when it's phosphorylated. It phosphorylates the SMAD proteins inside the cytoplasm, and different SMADs collect together and form an aggregate, a trimer, which then allow transcription of critical genes, both for fertility as well as for metabolism. This is a 3D reconstruction model showing you what a SMAD trimer looks like, what happens when you have 3 wild-type SMADs and one which is our mutant. And it shows you this is what the wild-type looks like. The mutant causes a different collection of these proteins. And our preliminary studies show that in vitro, this really damages the ability to transcribe those genes. And currently a mouse is being made that has this knock-in. We're waiting to see if it recreates the phenotype of the patient. So, I think it's just an interesting process of discovery, beginning with this patient-derived clue. Here's another patient. This is a 29-year-old Hispanic man who came in with DKA, then stopped taking his insulin, did fine for 8 years. So he looks like he's one of those B+ people, right? But 8 years later, he comes in with a second episode of DKA. Although he's, not overweight, he's got an interesting phenotype. He gets a treatment for DKA, but this time he cannot come off insulin. So he started off as B+. Now he's clearly B-. He needs insulin all the time to avoid DKA. So what happened? Why does he transition? So his current status would be A-, B-, ketosis-prone diabetes. And it turns out that if you take these folks who are, if you remember, in the bottom right-hand quadrant of that 2x2, about a quarter of these people end up having a monogenic disease, right? And interestingly, the kinds of monogenic defects they have are very unusual. In that list that I showed you of Modi syndromes, HNF1 alpha was one of the commonest kinds of Modi. But PDX1 was one of the rarest kinds of Modi. But PDX1 is enriched in this particular phenotype of patients. And this patient has that. He has a novel variant in the proximal promoter region of this gene. So what does it do? And is it linked to his diabetes and his particular phenotype? Well, this is where another technology comes in, which is incredibly helpful, which is stem cell technology. So what is done in this case is to explore this particular variant in the promoter region. Skin biopsies are taken from the patient, from controls. The fibroblasts are taken and converted into iPSCs. The iPSCs are very healthy in both the patient in P and the control in C. This is to show you the way to differentiate those stem cells into the beta cells, which is where you think the defect lies, is to take them through these stages. So stem cells follow a very typical set of stages to get to becoming an insulin-producing cells. They go through what is called a definitive endoderm stage, and then a pancreatic progenitor stage, and then an endocrine progenitor stage, and finally beta cells. And at each stage, they have these very distinctive transcription factors that mark that particular stage. Anyway, the point is that if you then try to differentiate the patient's cells into beta cells, there's a big drop-off that happens right at the sort of border between a DE and a PP stage. So why is that the case? Well, if you do metabolomics now on those cells, it turns out the big difference between patients and controls through a principal components analysis is in certain metabolites, and that metabolite turns out to be leucine, the same one that we found to be abnormal in patients with A- B+ KPD. Now, why does leucine make a difference? It turns out that leucine is fairly toxic at that particular stage of beta cell development. So the controls can handle a fair amount of leucine in the medium, even if it's increased. The patients don't do well even in regular amounts of leucine, and they die off if you give them even more. And the reason is because leucine activates something called the mTOR pathway, which is known to inhibit beta cell development. That's great. Our friend leucine comes back into the picture for this syndrome, but why is it connected with that particular gene variant? Well, to prove that it's connected, we did a couple of things. One is to take the patient's variant and correct it using a CRISPR-Cas method. And if you correct it in the cells, then what happens is that the level of PDX1 that's produced, which marks the proper development of those cells, is at this level and controls. It's at a low level in the patient, uncorrected. But if you correct the patient, it comes back almost to the right level again. So this shows that the variant is necessary for the problem. To show that it's also sufficient for the problem, you do the opposite experiment. You now take the wild type patients and you knock in the variant. And if you do that, then the wild type goes from producing lots of PDX to much less PDX. So I think this is sort of a complicated process, but it shows that using modern tools, particularly by beginning with characterizing the patient and sort of not ignoring their peculiarities, you can really come along with lines of discovery to figure out new mechanisms of understanding diabetes and also of categorizing diabetes. So I'll stop at this point. Thank you for your interest, and thanks to a lot of people on our teams that have helped make this happen. I'm happy to take any questions.
This selection, if you can repeat the question.
Okay.
Not you, but the question. This
Sure.
on the here.
So we're fascinated. So it's wonderful. Biochemistry and cellular physiology we don't usually think of, and also bring in immunology, really important advances. But one of the advances that we've seen recently in diabetes is the understanding of the relationship between diet and the development of diabetes, particularly the microbiome. And the bacteria that lead to a dysbiotic microbiome leading to all the cardiovascular risk factors, hypertension, hyperlipidemia, and particularly diabetes. Over 42 studies saying you have this bacteria in GI tract versus that bacteria. I mean, Pneumococcus is bad for you, and Klebsiella is bad for you, and Bacteroides is good for you. Well, they're talking about specific mechanisms within the diabetes realm that you've described so well. And of course, a few days ago, we woke up to AMA touting the two doses of red meat per day, or per week, resulting in type 2 diabetes. Where does that fit in? How many of these syndromes could just be avoided if we fix particularly the American diet?
So I was warned that you might ask me a question like that. And even though I came prepared, I don't have a great answer, but I can give you one very sort of sliver of an answer. So the microbiome is incredibly important, but you can imagine that since, like many other omics approaches, it takes the aggregate from large numbers of people. And the issue always is with a single person, what does it mean? However, despite that problem with scale, we have done some microbiome studies in one particular phenotype of KPD, the guys that we're calling A minus B plus, the fellows who have this interesting leucine arginine kind of metabolic defect. And it turns out that in their microbiomes compared to controls, there is a preponderance of bacteria that I'm sorry, not the leucine, but the arginine pathway. Remember the guys who responded so dramatically to arginine? It turns out that their gut seems to have a preponderance of bacteria that seem to metabolize citrulline. And citrulline is one of the products of arginine, primarily in the gut. So it's another little clue that, maybe either as a cause or as an effect, the bacteria are also sort of synchronizing with this, alternate pathway of arginine synthesis. So it's a very long way from connecting that to a cause. But it was an interesting observation that was published along with that paper. We haven't done anything more than that because it's a huge issue, obviously, right? I mean, it's not something you can tackle on a single patient basis. So actually, we decided reluctantly in Radiant not to also take stool samples because it was like one more thing to kind of do. But we may reverse that because, you learn so much by actually trying something. we had no idea that 10% of people that you select clinically will actually end up giving you strong monogenic clues. Everyone tells you monogenic diabetes is vanishingly rare. Well, apparently, if you circumscribe your phenotype sufficiently, it becomes less rare. You know, instead of fishing in the ocean, if you put all your fish in a barrel, you'll catch more fish. You know, I mean, it's kind of like doing that. So I think that some of the concepts of how you even apply genomics or the microbiome might change. So thank you. We'll take that suggestion. Yes.
So I'm curious what do you think about how durable some of these categories are? So, you know, at diagnosis, are they locked in for life, or do you keep shifting between some of these subtypes? And follow that, I'm curious, is there certain points in the diagnosis, so whether your beta cell production, autoinflammation, that associates more with outcomes like infections or cardiovascular? It's thinking about inflammation as being a background of diabetes.
Yeah. Well, that's a fantastic question. I mean, you've asked a lot of questions, but I think the fundamental one is, can you ever hang your hat on a diagnostic category when you're seeing the patient for a short period of time? Because unless it's stable, then it doesn't tell you very much. So within the part that we know pretty well, which is the syndromes of ketosis-prone diabetes, the notion of stability was very, very important. What's the point of calling someone A- or B+ or whatever it is, if they're going to change down the road? Well, it turned out that to the extent that we've longitudinally followed these folks and repeatedly done some of these tests, that the categories, most of those 4 categories are remarkably stable. The one that is not stable are the guys who are A+, B+, because they seem to, you know, if you catch them at a different window, they seem to change. So you have to be aware of that. And then if you could either say, well, you know, I gave them the wrong diagnosis, or you can be curious and say, why did they change? And you can see that in that one instance of that patient who did change, there was a reason for that. He sort of had a second hit. He was not only exposed to all the environmental things, but he had that particular genetic hit, which made him susceptible to the change. So it's really like looking for a needle in a haystack, but then you have sort of better tools to pick out that needle. And I think you have to be totally aware of the fact that things might shift. So I think we always work in kind of a conditional way. We say, this is good for now. The categories may change. So what is a stable biomarker? You know, probably a very stable biomarker is a gene variant. But then you have to be able to categorize people based on their genes, which is a huge task, right? The oncologists have done it. So I don't see why endocrinologists should not, right? Anyway, it's a great question. I don't have a better answer than that.
There's a couple of questions from our chat here.
Okay.
I'll read. One is from Dr. Robert Evans. He's in our EMT oncology group. With the wider beta cells and insulin in particular, such a target for autoimmunity, the liver makes just as many diverse proteins, yet there are precious few autoimmune fatal cellular or liver-based protein autoimmune syndromes. Beta cells somehow protected from early T cell induction during development.
So these are great thoughts, and being only an accidental kind of immunology type of person, I don't have a good answer. In general, though, it is interesting that most endocrine organs are very susceptible to autoimmunity. Thyroiditis is very common. You know, type 1 diabetes happens. You know, autoimmune adrenal disease leading to Addison's is very common. Even the pituitary. So there is some connection between the huge volume of proteins you're producing and the, you know, clogging up of your endoplasmic reticulum and the inflammatory responses to that. Number one. Number two, the fact that you're always secreting lots of proteins. And therefore, if it happened at some point of your early thymic development and you didn't actually recognize all the epitopes. So there's a lot of theories around that, but it is very curious that endocrine organs or hormone secreting organs are particularly susceptible to autoimmunity. But having said that, I've exhausted my knowledge of this topic.
And one more, this is from Dr. Matt Cade, who's from our liver expert in the GI division. So wants to know, where do endocrine disruptors fit into emerging diabetes subtypes?
You know, it's interesting. I was talking to Dr. Moshe Gundram about that yesterday, because, you know, you have this site out here to look for environmental toxins. I think it's huge. And I think you have to approach environmental causes of complex diseases in the same way as we do other omics, right? There's genomics and metabolomics, and there's also environmental omics. So until somebody comes up with a way to really take that massive data and be able to shrink it down to things that affect particular people, we won't know. We were talking about the fact that there's one particular interesting syndrome in India where you get diabetes because your pancreas calcifies. And there's a strong evidence that has to do with the environment. We haven't narrowed down to what it is, right? So if you look at the blood of those patients versus what's in the soil and in the environment, thiocyanates seem to play a role, but how does it get into your system? What do you eat that does it? So I don't know the answer. I think it's terribly important. And maybe Dr. Williams could tell us how we should go about that. Yeah.
So some comments about euglycemic decay in the setting of shear, which is such a big game changer in cardiometabolic system. So what are your thoughts on that in the setting of diabetes in patients with cardiovascular?
So I think it's kind of at the theory level, and the notion, I guess, is that somehow it has to do with upsetting the insulin-glucagon ratios. Exactly how that happens, I don't know, but the drug seems to be able to do that, probably at the level of the gut, because those receptors happen both in the kidney and in the gut. I don't know that anyone's narrowed it down more than that, but it seems to happen. I mean, there is a certain frequency of patients who get these wonderful SGLT2 drugs that cure heart failure and all kinds of things, to getting, DKA despite. But I wouldn't actually call it euglycemia. They don't have terribly high sugars, but they're usually a little bit high. They're diabetic patients, right? So I'm just wondering. I don't know how to answer that question. It happens. Sorry. Yeah.
The diabetes prevention programs, outcome studies, we get the same thing that we did in Bay, looking at inflammation and those markers, especially the T-cell one, progress.
Yes, the problem with the T-cell test is that even though it's been very revealing, the way it was done, it's incredibly laborious. I mean, it requires 30 cc's of blood from the patient and about a 5-day assay. So very old-fashioned. There must be some new ways of doing it. And I'm really trying to get labs interested in trying to develop this test. It would probably take the lifetime of a young investigator to do that properly, to come up with a clinical test. So I think these things kind of show us the way, and then somebody has to figure out how to make it feasible. Yes, so many cohorts give us the substrate to do that. Stored samples give us a substrate to do that. The test at the moment is very crude. All right, thank you all very much for your attention. Bye. Oh my God, just everybody get beeping over the head with that?
We give you the bat. So this is our it's autographed or engraved, and we want to thank you very much for a very stimulating grand rounds that gave us so much information and really changes the way we think about diabetes.
I'm really honored. This is such a pleasure to be here, and this is just a huge bonus.
Absolutely. Thank you so much.
Thanks.
Thank you, everyone. Okay.